This is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. I'm Vahid Sadr-Azadi, the only non-medical person on this on this podcast today. We've got a very special podcast here as Dr. Zain Hasan from Los Angeles, California, where he currently resides, is a trauma anesthesiologist at Cedar Sinai Hospital. Zain, thanks so much for being with us, flying all the way over here to be with us on the podcast.
Beautiful South Bend.
Yeah, I'm excited. I've heard a lot of good things about South Bend. Never made it out here first time. Very excited.
Hey, you flew 5 hours to dance with Brian. So.
That's true. That's true. Don't reveal too much yet.
Yeah, we're not going to reveal that much. But hey, welcome to South Bend, Indiana. We have a lot to talk about today. We've all seen your podcast or your reels and your Instagram, and honestly, follow him on all social medias if you're not already. I love your Costco series that you're doing right now.
I appreciate that.
Do you get any looks while you're like going down the aisle of Costco?
So you'll be surprised. In Los Angeles, everybody's an influencer. Yeah. So nobody bats an eye when you take out a camera and record yourself doing anything. I mean, there's film crews everywhere, so it's kind of like second nature. Airports, Costco, gas stations, wherever.
We get looks here for sure.
Yeah, we everywhere.
We ran a race this morning.
Yeah, I was gonna bring my FX series camera, like a cinema light camera, and my wife was like, "Yeah, I think you need that for."
We ran a little 5K this morning, and he was gonna.
I was gonna bring the heavy lumber. Yeah. Anyway, let's just talk about some of your background and your education. Let's go through that first, and give folks just kind of an introduction, and then we'll get into some of the hot topics we want to discuss.
Yeah. Okay. Yeah. No, I am board certified trauma anesthesiologist, born and raised in Maryland. Born in Virginia, raised in Maryland. Did my medical school in Erie, Pennsylvania, residency in Buffalo. So I've been in the cold pretty much my entire life. Then we went to, got married to my wife. She was surgical training at Mayo. So we went to Minnesota. Absolutely loved Minnesota.
Shout out Minnesota.
I know you're from Minnesota. Love Minnesota. Fantastic place to live. Land of 10,000 lakes. Absolutely the best place to live, I think, in the country. And then we went to Pittsburgh for her cardiac training. And now we're in LA. And who knows, maybe we'll be leaving. I'll cover that a little later, but been all around the country. And seen all different types of anesthesia.
Why trauma anesthesia? Like why specialize in that?
That's a great question. So I was in Minnesota working at Hennepin County Medical Center during the time when the George Floyd incident happened. And that was almost akin to being in a war zone. We had Army personnel outside with AK-47s. We had Humvees. I mean, there was fires in the street. I have videos on my phone driving in from Rochester where the city was on fire. So It kind of sparked a little bit of a passion for me. I mean, it gave me a little bit more thrill than I usually get from anesthesia. So I decided to specialize in it, and I love it. And I love the shtick. I love calling myself a trauma anesthesiologist too.
Yeah, trauma's not my thing. I haven't done that since training. But
did you do any trauma training, or how much do they have you do?
So I trained at the county hospital in Indianapolis. Half my training. So, and then we also did some trauma at the private hospital. I don't know. We probably did 10 months of trauma. I mean, throughout training. I don't know. I didn't like the call. I didn't like the call. That's why I didn't want to. I don't take calls, so I didn't.
So are you on call? Is that
so? Yeah. So when we were on call, I mean, in Minneapolis, I don't know what the situation is in South Bend, but in Minneapolis, it's kind of a violent place. Certain times of the year, not when it's cold, but those 3 months when it's above freezing.
That people are actually out.
There's a lot of. I mean, you're talking about boat injuries. You're talking about gunshots. You're talking stabbings. All sorts of crazy stuff. So it's different. I mean, my wife, when she was at Mayo, a trauma activation was an old lady falling down the stairs or somebody falling off their tractor and breaking a leg. In Minneapolis, a trauma activation was somebody getting run over by a car
or shot.
Clamshells, meaning their chest was wide open. They're pumping their heart with their hands when they come in.
Wow.
Just crazy stuff. So it's fun. It's exhilarating. But it's different from each place, wherever you go. Now at Cedar Sinai, it's a little bit more of a, how do you say it, a different population. So trauma is more akin to Mayo Clinic type of trauma as opposed to, inner city trauma.
That's interesting because you would think that
Los Angeles
you would have, but are you saying that you saw more traumatic experiences and cases in Minneapolis than you have in LA.
Oh, 100%. I mean,
Wow.
I would say the amount of gunshot, I've seen maybe 2 gunshot patients come in the past year at Cedar Sinai.
Really?
In Minneapolis, it was, 2 to 4 a night. So it's totally different.
Any celebrities that you've operated on?
You can't talk. You know he can't talk about that.
No, but I have to ask. He can either say yes or no.
Oh, true. You can say yes or no.
I can say yes. I can say yes.
Interesting.
So my first rotation. This is maybe why I don't like trauma. My first clinical rotation as a medical student was ER, and I was in the Methodist Hospital, which is the big non-penetrating trauma center in Indianapolis. And that first night, I had a lady who fell off a motorcycle on the highway, had a degloving, and her leg was basically pointing out.
Yeah.
And then like 20 minutes after we finished with that one, a guy came in, also motorcycle, who hit a branch and had actually like brain matter coming out of his head. And after that, I was like, I don't want trauma. I don't want to do trauma. I'm done with this.
I can tell you some of the craziest things I've seen. I mean, boat injuries, you would never believe it, but if you get a propeller to a thigh, it looks like Swiss cheese. I mean, they come in and it's like,
I didn't even think about that.
Yeah, it's. I mean, in Minneapolis, there's 10,000 lakes, and they don't get to use them 9 months out of the year. So 3 months, it's overpopulated. A lot of people in the water, boats traveling around. If you get hit by a propeller, it's an insane injury. I mean, it's hard to see because it looks like Swiss cheese. It looks like your leg turns into Swiss cheese right down to the bone. So. But it's interesting, but
well, let's hit on some topics here because I know there's a lot that we want to pick your brain about. I think the first one, and that we've discussed at length, is let's start here. Where and I've asked Brian this question: where do you see anesthesia going over the next 10 to 15 years?
100%. I'm so happy you brought this up. I've thought about this. I talked to a lot of people about this. There's a shortage of anesthesia providers across the country. I mean, it doesn't matter if you're an MD, a CRNA, an AA, it doesn't really matter. I think after the pandemic, a lot of anesthesia tends to lend toward lifestyle specialties. And so after the pandemic, I think a lot of those baby boomers that were on the fringe, whether or not to retire,
they were out.
They were out. So, and the ones that didn't retire went to surgery centers. Mm-hmm. So there's a massive dearth of anesthesia providers across the country. How do you solve that? I mean, there's 2 ways, right? You can increase the number of anesthesiologist residency spots. That takes forever. Or you can start incorporating the CRNA model. California is very slow to incorporate the CRNA model. I think the future, absolutely working hand in hand with CRNAs, AAs, whichever, but there's no other way to do it, really, in my mind. I mean, you can't really physically staff all the surgeries that need to happen for all the baby boomers that are getting older, that are breaking their hips, need knee replacements or shoulder. It's just impossible. Yeah. So unless you want everybody to wait years to get a knee replacement, you got to up the staffing. The only way to do that is with CRNAs, AAs. So that's my opinion. I think the future, I think our specialty is a little bit behind in adapting that.
So you said the same thing. Right. When was, I don't know if we talked about this, but when was the heyday of anesthesiologists, like 80s, 90s?
So there was a huge decline in the number of anesthesiologists, like late 80s, mid to late 80s, and then the specialty changed a ton going into the early 90s, and people were, anesthesiologists were making unbelievable amounts of money.
Yep.
Early 90s, up till probably the ACA, so probably Obamacare, up until about 2010, give or take, 2008 to 2010, and then a lot of stuff changed at that point, and
the bundling of payments really.
Yeah, bundling payments was huge. Not being able to own hospitals or surgery centers. A lot of that stuff changed with the ACA.
Yep.
So there's no way to get back there, you think?
Well, repeal Obamacare, but
yeah. The genie's out of the box. Yeah. I mean, if you have a chance, throw it up on the screen. If you look at the stock prices of United Health, CVS, all the medical insurers from when Obamacare was passed, and I made a video about this. It's pretty interesting. It blew up.
We'll link it.
Yeah, absolutely. The stock prices from 2012, was that when it was passed?
2010 was implementation.
Just look at their stocks were gradually increasing, then it was just vertical. Yeah. They went absolutely vertical for the last 8-10 years. They've been an amazing investment because you're having everybody pay into their subscription model, where before it was this government that was subsidizing. Now everybody has to pay, and their stock prices have gone straight up. And everybody that suffered, it's a lot of physicians. I mean, you hear about cuts every single year to the Medicare reimbursement for every physician, not only anesthesiologists, but everybody's getting cuts. And it's unfortunate, but the way it was spun was that this is better for everybody. But in reality, this, insurance companies are in the business of not paying out.
Right.
They get the money, but they don't pay out the money. So that's my opinion on it.
I mean, if you're going to go that direction, just make it Medicare. Make everybody under
Single
Medicare.
payer,
I mean, at least then we know, right? But instead, 75% of the money that gets paid into the healthcare system is going in the pockets of the
Oh man,
CEO.
look at their salaries.
Yeah,
Unbelievable salaries.
So United Healthcare owns Optum, who owns Change Healthcare. We talked about the big Change Healthcare issue. So if you look back, they made more money after that than before.
Yep.
So they used that whole thing to make themselves more money.
Yep.
When we all got screwed. I mean, I don't know if you were affected by the Change Healthcare issue, but
I was not. So I've always been employed. So I've never had them. But I know Change. I mean, United Health is not a great company for physicians. A great stock to invest in if you think about it. I mean, it's just unlimited subscription revenue every.
You're a financial guy too, right?
I did do finance undergrad. I mean, it's a fantastic. I haven't posted this video yet, but I've made it several times talking about how United Healthcare and all these insurance stocks are not great for the physicians. But if you're an investor, it's the Warren Buffett model where they get money from the insurance. And then instead, the problem with United Health is they're not investing in stocks the way Buffett did.
Yeah.
But they can pivot to that at any point. They can start putting all these giant lump sums of money into Apple, Google, and they can skyrocket their profits pretty easily. So I've said it a lot. I mean, it's not financial advice, so please, please don't take my.
Yeah, but we're not attorneys. We're not your financial
Not
advisors,
financial advisors.
and we're also not your doctors.
Exactly. But no, the companies themselves are not great for physicians.
So in 2024, you guys saying and both agreeing that we're going to see the most anesthesiologists right now in history right now, and it could shift basically to where we see a decrease in the number of anesthesiologists over time.
Relatively, yeah. I mean, there's more retiring than we're creating. So if you look this year, 2024 is the first year that there's more CRNAs practicing in the United States than anesthesiologists.
Yeah.
It's going to continue,
Yeah.
I don't know if you can... Anesthesiologists are going to level and then decrease, and CRNAs are going to keep skyrocketing. So
Yeah.
It's an interesting topic because we've had a lot of comments about the relationship between anesthesiologists and CRNAs and AAs. How do you view the relationship between the 2 and the 3?
So I personally worked with AAs and CRNAs. Are you asking the question about anesthesiologist relationships? In my opinion, the more anesthesia providers, the better. I don't have a hierarchy. I've worked a majority of my time with CRNAs. Majority of the CRNAs I work with are fantastic. Some of my best friends across the country at all my practices are CRNAs. So I think they're fantastic. I think AAs have their own role in the hierarchy of things. But I imagine with enough time, they'll probably be close to the same level as CRNAs, if not better or the same. I think the most important thing is that the care team model is what we need to continue in the future because, and I haven't posted this video either, but I was going to post
a lot of videos.
I have a lot of videos in my head.
This
one is done. Yeah. But in my mind, 2 heads are always better than 1 in any situation because I work solo right now about 98% of the time in Los Angeles. And I know there's situations that I run into where there's difficult patients, and I'm like, I wish I had another hand, another head here with me in this room taking care of this patient.
Somebody who knows what they're doing. Yeah, I'm the same way. I'm usually the only physician in the practices I'm in. I'll call the CRNAs in if I need help.
100%.
I'm just anybody who knows what they're doing, who's a capable anesthesia provider, and I need help.
Are you talking about help in the case? Like, what are you?
Yeah.
So I'll give you an example. In my previous practices, when you take care of pediatric patients, a lot of the times they don't have IVs when they come in. So what you do is you mask them down. You give them nitrous or sevoflurane, you mask them down. So essentially, you hold the mask down until they pass out.
Yeah.
But at some point they stop breathing. So you need to be able to get the IV in order to induce them safely and put it to breathing tube before they stop breathing. So if you have 2 people in the room, one that can manage the airway, one that can put an IV in, it's fantastic. It's smooth. There's no risk really to the kid. A lot of places, when you have a solo anesthesia provider, you have somebody else placing the IV, and that makes it. If they're good, it's no big deal. But it's that 1% of the time when things go wrong, and I talk about this a lot on my channels. 99% of the time, anesthesia is safe.
Yeah.
It's safe. It's not going to end your life. It's that 1%. You really, if you have another pair of hands, it can be the difference between life and death. So, in my opinion, two heads are always better than one.
I learned where we, even at Riley, the nurses wouldn't do the IVs. We had to do them. So they tipped the hand up, and I'd have to put the IV in one-handed. So I got pretty good at doing that.
That's amazing.
It was fun. Yeah. I mean, but I don't do that anymore. But no, I mean, I totally agree. If you don't have, especially in pediatrics, if you don't have a really good nurse to put the IV in, you're kind of, I mean, honestly, and I don't know, we don't want to get into too much practice patterns or whatever, but what I used to do when I was by myself is I just throw an LMA in. I mask them down, throw an LMA in, and then get the IV.
Yep.
There's some risk to that, but at least their airway's somewhat secure. So
How do you feel about locums? That's one thing.
We were talking
I
about
just
this
went
in the
right
car.
to
Yeah.
just went right for the
Me working I love locums. I think it's a fan. I mean, are you talking about locums providers in general, or me doing
just
locums?
the whole atmosphere?
Just the whole
So we talked to just a little history here. We talked a little bit about how it's basically locums is bankrupting the entire healthcare system, right? But your opinion.
So I can tell you, I've seen insane offers for locums that are desperate needs across the country. I mean, I've seen mind-boggling numbers that people are offering. This gets back to my point that, and so Brian, I'll tell you this. I think that we're at an inflection point in anesthesia in general. I think people are starting to realize that the entire healthcare system comes to one focal point, especially in the surgical specialty. And surgical specialties drive 60 to 70% of the revenues for all hospitals across the country. That focal point is anesthesia. And if you have a shortage of anesthesiologists, you can't do the procedures safely. So I think that now people are starting to realize that, hey, we need to actually, administrators are starting to realize that, hey, anesthesia departments are not just a service that's provided by an ancillary group. This is critical to the healthcare across the country. But it's taking some time to realize that. And because of that, it's slow to catch up. So the money that they're offering for locums right now are mind-boggling. I mean, I know so many people that are leaving private practice to go into locums because, one, you get the flexibility, you get control over your own schedule, you get your own vacations, and then you get a great salary too.
So they're acting as a free agent, as of
that's supply and demand right now.
Yeah, it's nuts. It's nuts. It's funny though. So a hospital or whatever center or whatever will pay ungodly amounts of money for locums, but then come back and complain about the contract that you have with them and how expensive it is.
100%.
So like, oh yeah, you've got this group and the group's so expensive, but we're going to pay 3 times as much to have a locums provider come in.
And that usually upsets the people that are working.
Yeah, of course it does.
Regular staffed employees all the time because you're paying 1.5, 2 times their hourly rate to bring somebody in from the outside.
So who is minimizing? I mean, as a patient, right, in this healthcare world, who is minimizing the health care that anesthesiologists are putting forth?
Hospital administration, 100%.
Yeah.
I don't understand why that is, though. I mean, like, why would you minimize one of the most important positions in an operating room?
Because we don't generate revenue for the hospital.
Yeah. We don't bring patients in. We're more of like a radiology specialty or somebody that just provides a service inside the hospital.
Like the janitors.
Exactly. You're not bringing the patients in, or you're not bringing the money in. You're not bringing revenue in. But now people are starting to realize that everything comes to one fulcrum, and that's the anesthesia department, which in a lot of places across the country are saying, hey, are pushing back, saying, hey, we're not going to work these crazy hours anymore. We're not going to take less money, all these kind of things. And they have the ability to do it right now while the iron's hot because there won't be enough anesthesia providers. I think the projections are 7 years to catch up?
At least.
So they have the opportunity now to do that.
If you're a medical student, let's continue to talk about this. If you're a medical student and you're kind of looking at the different pathways, that's what we called it, the different pathways of anesthesiologists or anesthesia, what should I be looking at? Is it better to take the CRNA route? Is it better to take the AA route? Is it better to go the full distance or do the locums? I mean, what is the better bang for the buck right now for medical students who are looking at the pathways forward?
It just depends what you want to do. I mean, if you're, for instance, you're already a nurse, right? There's probably, and you want to do anesthesia, there's probably no reason to go back to medical school. Just become a CRNA.
Yep.
I mean, for me, I wanted to go to medical school. I wanted to learn everything, right? Because I didn't know what I wanted to do when I started anyway. But I also kind of wanted to be like captain of the ship, right? Like, I mean, people who know me, I like being in charge, right? I like running the department and all that kind of stuff. You don't say. Worst
impression.
Worst experience of my life was having IV Valium for a procedure, and knowing I was not in control. But anyway, no. So I mean, it just kind of depends what you want. Especially in anesthesia, if you're going to go into anesthesia, there are so many different routes. You just figure out, hey, I just want to go work at a surgery center. You can do that out of any of those specialties, whether you're a CRNA, a doc, or an AA. You want to, do trauma.
Yep.
Probably, I would say the majority of trauma centers have anesthesiologists. I mean, probably trauma is better to go the anesthesiologist route. But I mean, there's options. I mean, I would talk to you and figure out what your options are, but I don't think there's a catch-all.
Yeah,
for sure.
I would tend to agree. I think each class is really good at something. I think anesthesiologists more cerebral. I think CRNAs are very good at meticulously getting the right medications in, doing the right things in the operating room that a lot of times anesthesiologists might gloss over because they don't think it's as important as the bigger issues, the heart or the lungs or whatever it is that they're worried about with the total anesthetic. So I think it's whatever you're good at. Like Brian said, if you're already a nurse, becoming a CRNA makes entire sense. If you are in high school thinking about CRNA, AA, or anesthesiologist, you just kind of have to figure out, hey, do I want to be a doctor and know everything? Do I want to specialize in anesthesia, or do I want to do the AA route, which I think is either 2 years or 3 years? I'm not.
That's 20. At least the one in Indiana is 28 months, I think. So you've got to. I think you've got to do. We did a podcast on this, didn't we? The different.
We did.
I think it's. I think it's undergrad. Then you have to take the GRT or something like that, and then it's 28 months, I think.
Gotcha.
So.
Dr. Zain Hasan is joining us here from LA. What a special treat for us, Brian. And we're talking about all the different pathways forward for anesthesiologists, anesthesia, where it is in today's scope of practice and medicine. And we're going to touch on some different topics, too. We really want to touch on Ozempic and some of the other weight loss type drugs that is really, really hot right now on the market. Let's talk about another hot topic that just came down in a ruling a couple of weeks ago, and that's non-competes.
Oh, yeah. You like this too. Yeah.
I know you specialize in finance too, so I mean this is a big ruling that came down. Not only for hospital systems and providers and doctors, but for broadcast professionals too. I mean, this is a huge topic that has come up. And employees love what's happening because it really gives them an opportunity to go work at other places without being limited.
Yep.
Guess who's fighting this now? Because there's a bunch of appeals now. The hospitals,
I'm sure. Yeah, 100%.
Yeah, there's a theme here.
Yeah, exactly.
But this is what we talked about, though.
Right.
They're going to be fighting this in courts for maybe months and years.
Yeah.
But there's not going to be, in my opinion, there's not going to be a stay to this because it's not a law. It's just a ruling, right?
Yeah.
So even if they appeal, I don't think that they're going to be able to stay it. So I think it's going to go into effect, and then if the courts say it's not legal or whatever, then they'll turn around. I don't know how you possibly could say it's not legal, though.
Yeah.
I mean, I think that the hospital systems are going to have a really hard time unless somebody's in their pocket. I didn't say it. Turning this around. I mean, it's gonna continue. I think.
Dr. Hasan, with a financial background, background. Give us kind of your thoughts on what's happening here and some of the appeals that are happening.
I think it's huge. I think so. California has had this ruling in for years already. The tech company, I mean, this has been going on in California. There's no non-compete. So you can go from hospital to hospital whenever you want. It's majorly in there for the tech companies. So software engineers can hop from Microsoft to Google to Amazon within like 3 months of each other and boost their salaries. And those companies are doing absolutely, they're doing fine, even though they have to pay a little bit more. The big concern on the employers,
confidentiality side, right?
If you can't bring over IP, essentially, but if they can regulate that in the software side, which is way harder, way more like intellectual than actual patients, then they can do it in the hospitals. all these hospitals have non-competes. So if you work at one, let's say you work at the clinic in Cleveland Clinic, you can't go to the rival university hospitals for 2 years. And usually the contracts,
2 years.
Yeah. And usually the contracts, and there was a big lawsuit in North Carolina with the anesthesia group. They went
At Atrium, yeah.
Atrium. It took 18 months through court, and by the time they actually ruled and said it wasn't enforceable, most of the physicians had already left because they didn't want to. I mean, there's 18 months without salary, but what the hospitals generally tend to do is they put in their contract that you cannot, if you work at that hospital, you cannot work at any hospital within 90 miles of any affiliated hospital.
Right.
So if you worked in Cleveland and they have some suburban hospital that's like 40 miles outside of Cleveland, you have to go another
Basically
60
Cincinnati.
miles. Yeah,
you have to go to Cincinnati or
you have to go-
Indiana.
to work for 2 years. So I think it's fantastic because what that allows, so when you have that type of setup, there's a lot of backdoor deals that, hey, we're going to pay, let's say we have an orthopedic surgeon. We're going to pay him X. You guys can pay him Y. Let's keep it within 10%. We might give a little more bonus. You might give a little more salary, but let's keep it, level. Let's not compete with each other for talent. So it will inhibit that from happening. So it will raise physician salaries, nurses salaries, any medical provider salaries, software engineer salaries, everybody. So it's good for anybody who's not at the top of the food chain.
Yeah.
Yeah.
In my opinion.
Yeah, no, I totally agree. And we talked about it because I'm a business owner too. I mean, for me, I've never had non-competes in any of my contracts. We do have non-solicits with the facilities, but those have a very reasonable price to them, right?
Yeah.
And so I don't have a problem going to a hospital and saying, okay, you want to take 6 of my providers, it's going to cost you X amount of dollars.
Yeah.
In the long run, it's going to save you. So fine. But I've never put a non-compete, and I only signed one my entire career, but I've never.
Which one was that?
So let's bring it back for 1 second. We were talking before that hospitals don't value anesthesiologists because they don't bring any business to the hospital, right? But they throw these non-competes in. We don't bring any patients to the hospital. None. Maybe the pain docs bring patients, but 99% of anesthesiologists don't bring any physical money revenue to the hospital. Yet, however, there's this non-compete in your contract because they're afraid you're going to steal patients, stealing revenue. So there's a lot of things that don't make any sense that are built into medicine in general. So yeah.
I mean, I cannot think of any patient who's ever said, well, maybe some on my on my Instagram, but I can't think of any patient who's ever said,
user 56593.
I'm going to that hospital. I'm going to that hospital because I want that anesthesia provider. Nobody's ever said that.
Nobody says that.
Yeah. No, it's interesting. I mean, in the broadcast community, I mean, we're dealing with the same stuff. I mean, you've been trying to not necessarily go across the street, but being limited to where you can go in the same community. Let's say you don't want to leave the community. You're handcuffed.
You're stuck,
You can't do really anything unless there's an agreement with the other company that says, hey, we're gonna pay you X amount of dollars. We're gonna pay for your penalty. And that's just gonna be the way it is. But that doesn't happen very often. We're continuing our conversation with Dr. Zain Hasan here in South Bend, Indiana. He made the flight. We got to ask you, what did you fly, and were you able to fit your bags under the seat and in the overhead compartment?
I flew Delta.
Okay.
Big Delta fan. Went through Minneapolis, and I did it. I was able to fit my bags above, so it worked out well.
Really?
Didn't have to
From
check
Minneapolis? Oh, yeah, Minneapolis. You took the
little tiny Bombardier
CRJ 900, which is a little bigger than the
700s that we typically fly.
And way bigger than the 200s that you take from Chicago to South Bend.
They cycled those out.
Did they really?
Yeah.
It's a CRJ 550 now.
Wow.
Yeah.
So a little bigger.
A little bigger.
All right. Yeah, that Chicago to South Bend flight is...
I will say I hate those small planes. I absolutely...
that's terrible.
The turbulence is the worst. It gives me so much...
I'm going to put you on the spot here because we asked Brian this question the other day.
Yeah.
We asked him the bottom 5 airports and the top 5 airports. Going to let you think about the top 5 airports because we haven't released that video yet.
Correct.
Yeah.
But I'll ask you what your bottom 5 airports are to fly through.
Off the top of my head.
Off the top. Yeah, right off the top.
Can I start with the worst first?
Sure.
Midway. I absolutely hate going through Midway. I think that's The most inconvenient airport in the entire country to get to. I mean, there's no highway that gets there. You take that little road.
Right.
So
for 5.5 miles.
Why would you fly through Midway?
Southwest.
Southwest.
Yeah. I mean, I was a resident when I was I've flown through a decent amount.
I mean, I'm not saying don't fly Spirit or Southwest, but
Yeah.
there's just,
Yeah.
Oh, Southwest is way better than Spirit.
Oh, 100%. I would say. You
Oh,
really?
yeah. I mean,
I've never actually flown Spirit, so I've never risked
I
it.
haven't either, but we sat in the seats.
we did.
Did you? I've heard
in
they're
BWI.
cardboard.
In BWI.
Yeah.
BWI.
Oof.
Yeah, BWI I guess, is a hometown airport for me. So I can't talk negatively of it.
There's a lot of people who came to BWI defense actually in
did,
the
they
comments.
Yeah,
I mean, the kicker for me in BWI was every store we went into, the people working in the store were on the phone screaming. Every single, how many? It had to be at least 3 of them we walked past.
We also went to Club BWI, which is like the lounge,
yeah.
the Priority Pass lounge.
Been there.
Left something to be desired a little bit on that one.
I'll agree with you on all those points, but I will say one thing about BWI that was very underrated. Chipotle used to do breakfasts like 4 years ago. BWI was one of like 5 locations in the country. So you could get breakfast at BWI from Chipotle. They axed it a long time ago, but it was fantastic when they had
We
it.
wanted Quiznos and it was closed.
Yeah, it used to be, yeah.
And so was Cinnabon, or what did you order?
Oh, yeah, Cinnabon.
Cinnabon, yeah.
Yeah.
It was close too.
My wife's a huge Cinnabon fan, so Mall of America actually is one of the final few places that they have one. So I think I might go there next week and get her one. So
Oh, you going to Minneapolis?
yeah, go flying to Minneapolis. Should be a fun time. I love Minneapolis.
I do.
All right, so number 4 on your list
Oh,
is
man, I have to, let me think about it. I mean, I think
Midway's number
Atlanta's-
5.
Atlanta's-
Midway's number 1, you said.
Midway is 100% number 1, the worst. LAX is a nightmare to get to, so I would put that at 5. I mean, it's a fantastic airport,
Sure.
but they've been making this people mover for almost like 3 years now. There's only one turn to get into LAX's roundabout, and thousands of cars are backed up. And there's a red light. It's a light. So all these cars come off the highway, and they're all just waiting there to make this right turn.
See, I've never had a bad experience. Maybe I just haven't flown there enough.
Yeah.
I haven't had a bad experience. Heather, my wife, and I usually go to the In-N-Out Burger that's right there.
That's a fantastic. I have plane spotting with my kids.
Yes.
Amazing. The best place to watch. I mean, LAX is a fantastic airport. I grade airports based on how easy they're to get to.
Yeah, we use some
So
of that.
they're
yeah.
difficult to get to. They're at the bottom of my list. LAX, you have to get there at least an hour and a half to 2 hours before, because you just don't know how long that line is going to be to make a right into the.
So you've got 1 and you've got 5.
Yeah.
You've got 3
I heard
more
Atlanta,
on your list.
I heard Atlanta come out. I will give a shout out to Neil. Was that his name?
Nick.
Nick.
Wasn't it Nick with Delta?
Nick. Yes, Nick with Delta. Thank you for reaching out. We're talking about how to make it better. But
Yeah.
I heard you say Atlanta.
Atlanta's there just because it's just there's so many people, and it's always a rush. You can't even get into the Delta Lounge.
It's always packed.
That's annoying.
The lines at the Delta Lounge.
That's horrible.
All right, so we got 2 more.
2 more. Let me think.
O'Hare?
O'Hare's not bad. I've never had problems at O'Hare.
Man, O'Hare is... It is the worst on my. I haven't made a list, but that is by far the worst airport in the entire country.
I don't know if it's that bad.
And it's doubly worse right now that they're working not only on the terminals, like renovating the terminals, but they're also renovating like the space, the taxiways. So it takes twice as long to taxi to your gate. So if you arrive there, like we're always, and it doesn't matter. I'm a freak show when we travel. I'm always like, we got to get here early. Got to get here early.
Yeah. You're one of those guys.
Yeah, I am. And I hate getting, like, I just like leaving myself enough time to go to the lounges and just relax. I don't like rushing to the gate or anything like that. But when you're scheduling a flight at O'Hare, you have to take all of those things into consideration. Number 1, gate to gate. If I'm like traveling from San Francisco to see my folks to South Bend, gate to gate, you're going at least between 2 or 3 terminals. So it's going to take you at least 25 minutes to walk between gates, even if I'm rushing.
But Concourse B has Garrett's, so
Garrett's is good.
Garrett's
How
popcorn.
about Detroit? What do you think about Detroit?
I
love
like
it.
Detroit grew on me.
Did it?
Yeah, so like I used to travel a lot for work
Best
to New
airport
York
in the
and
country.
went
Best
to
airport in the country.
Yeah, that's your. Well, you just gave it away.
There you
Haven't
go.
released the video yet.
Oh, Gotta bleep that out. You gotta bleep it. Bleep it.
What? And that'll come out after, actually.
Yeah, the video will come out before this podcast.
Yeah, it will.
Yeah.
So, link below. I love Detroit.
Okay.
I
actually like that their train is inside the airport.
It's
That makes
it's
it a lot easier.
simplified.
Yeah.
it has a lot of lounges.
And it's
They're
a
not
straight line.
overcrowded.
Yeah.
It's pretty
100
straightforward.
gates,
Yeah, the train going inside is
Yeah.
great.
Yeah.
O'Hare is by far and away the worst.
Yeah.
The worst.
Yeah.
Anyway,
I'll
you
put-
have two more.
I'll put Milwaukee on there.
Ooh.
Milwaukee's parking is
haven't done
terrible.
Milwaukee.
Yeah, it's a small airport. It's kind of like the armpit of O'Hare, I guess is the
Okay.
best way to describe it. Not a lot of great destinations and terrible parking. I'm
Yeah.
not a huge fan. And my number two, come back to me on number
All right.
two. I have a couple in my head. I got to think.
All right. In that time, let's talk about the hottest topic on the planet right now.
Let's do it.
It is Ozempic.
Ozempic?
Ozempic, right?
Yep.
So let's talk about that. I know you've talked about that on your channel a lot. We just recently talked about that topic.
Yeah.
Overall, what are your thoughts about kind of the boom
Yeah.
of not only Ozempic but some of these other weight loss
Yeah.
drugs?
Yeah. I think that majority of the foods that we eat are killing us. So I think that these medications have brought a lot of that to light. I don't know if you keep up with the headlines, but almost every 2 weeks there's a new trial. So Ozempic's being used in Alzheimer's. It's used in heart disease, anxiety,
Fertility.
depression, fertility, smoking, drinking, gambling. It's just
Like as a plus, like as a benefit.
yes. So
Yeah.
it affects the same part of the brain that all these foods and all these addictive habits affect. So what I'm starting to realize, and I don't think it's made it into mainstream media yet, but I'm starting to realize a lot of these processed foods, whether it's Doritos or sodas or whatever, are engineered with hundreds of millions of dollars to hit those same receptors in your brain. So subconsciously you think, hey, I really want to finish this bag of Doritos. I really want to finish whatever. And slowly but surely, we're seeing data come out that with Parkinson's or with Alzheimer's or with depression or anxiety, that if you just stop eating those things, a lot of aspects of your life are going to improve. So I owe a lot to, I've never actually personally taken Ozempic, but I owe a lot to it because it was the first video that I made on social media that actually caught fire. About a year and a half ago, I made a video saying, I don't know who needs to hear this, but I talked to a lot of patients, and I've seen quite a number of patients who've told me they started this medication, they've lost 10 to 15% of their body weight without exercise or changing their diet. And most of the comments were like, that's BS. There's no way. That sounds like voodoo. They're lying. But it blew up.
Yeah.
And then a month later, the Kim Kardashian thing came out, and it was, oh, she's taking Ozempic. She lost a lot of weight. Then everybody started taking, and then now it's like research study after research study saying, hey, stop eating this, stop eating that. And
Let's pause there and hit that topic
Yep.
about the foods we're eating
Yep.
are killing us.
yep,
Specifically, let's go into detail about that.
let's do it.
What are you seeing? I mean, like
Yeah.
a lot of the Food and Drug Administration, what they're releasing and what they're saying is okay
Yeah.
for us to eat.
Yeah.
What are you seeing that's in these foods that we're addicted to? That
Sugar.
Yeah.
I mean, sugar is a big processed sugar.
Yep.
that's the biggest
By far.
key.
Yeah.
Yep.
I mean, processed sugar is almost as addictive as caffeine or any hard drug
Cocaine,
that you can take. Yeah. You will rarely find somebody who's overweight making it past the age of 65. I'm talking obese. Like someone who's severely obese, it's very rare that you see any diabetic or someone who's severely obese going in for a knee replacement at 70. It's just very rare, So as these drugs come to fruition and they mature, I mean, we don't know all the risks. They've only been around for what, 2, 3, or maybe 5 years.
For weight loss. Yeah. It's
Yeah.
about, what did we say, about 10 years, 10, 12 years for diabetes.
Yeah.
But yeah.
And then the next iteration that's right around the corner are pills. So once the pills come out, they're already in phase 2 trials. They've already shown a reduction of almost 25% body weight in a year.
This is Ozempic making pills, or
Ozempic,
is it the
Mounjaro.
other?
Yeah, so
And Mounjaro.
Rybelsus is
Rybelsus.
the name of the semaglutide oral form.
Yep. And there's a better version coming out from Mounjaro, or Eli Lilly, which targets 3 receptors, and they have shown astronomical results. I think it's like 28% body fat reduction. So in my head, I mean, the finance person that I am, I'm thinking this could potentially be that golden bullet You could go on a weekend vacation to Vegas, drink, eat terribly, and then say, hey, I put on 3, 4, 5 pounds. Let me take this pill for 2 weeks afterwards or 1 week afterward and reduce all that weight that I got. So it is getting to the point where this thing can be a mainstream medication for everybody, because injecting yourself is a pain in the butt.
I hate it.
Going to the doctor, whoever, to get the needles, to get all that and refrigerate it. Nobody wants to do. I mean, people will do it, those that are motivated, but the masses won't. But if you can just take a pill once a day, you're gonna see that, and it has anesthesia ramifications for sure. But I think it'll be a silver bullet because they're showing that it helps with cardiac disease, decrease your risk of stroke, heart attacks, anything that can kill you. These meds are essentially preventing.
Are you? Go ahead.
No,
Go ahead,
no,
Brian.
go ahead.
Are you seeing patients? Like, are you asking them now?
Oh yeah, 100%.
Like,
It's a standard question for us. Are
The
you on?
the pre-assessment clinic. So when they call them a week ahead of time and say, "Hey, you're coming in for your total knee," the specific thing that they ask: "Are you on any of these drugs?" They name every single
Inhibitor
one, all the
or-
GLP-1 agonists. But they name every single one because patients don't realize what they're taking. All the orals, all the injectables. If they are, they say, "Okay, you have to not take that for at least a whole week." It's
and
standard.
if not more that we talked about.
Well, yeah,
possibly 2
It
weeks
should
now.
be 2 weeks, but the ASA came out 1 week. A lot of the times, a mishap comes that they're supposed to skip their last dose. So if they take it on Sundays, they have to skip that Sunday dose. So they're really 10 days or so from if they're having surgery on Wednesday, then you have a 10-day buffer. But a lot of times they don't realize that if it's a Friday, they take their dose on Sunday or Saturday, and then you're in that awkward position that it's been 6 days. You don't know. I don't know about you. I've done
cancel.
ultrasounds. Yeah, we cancel. I cancel personally.
You
I mean,
cancel.
elective
Cases, because we tried the gastric ultrasound thing. It's very unreliable. Essentially, you take an ultrasound and try to find the stomach and look if there's any particulates in there. If anybody's remotely obese, you're not going to really see anything. So you're just guessing. I've seen cases where they have actual food, like they'll have a hamburger from the day before in their stomach, like actual chunks of hamburger in their stomach when you suction it out. So they work fantastic for what they do, but public education about surgeries and these drugs has to make us mainstream.
Yeah, the ASA, I've heard anyway, the ASA is going to change it to at least 2 weeks, so that takes some of the confusion out. But if you look at the half-life of these drugs, they're 5 days to a week. So you want 5 half-lives for the drug to be gone. That's 3 to 5 weeks, right? I mean, they should be off that long. But
I asked Brian this question, honestly, the same one. What is the biggest negative you see about this drug? And we've had, I'll read a question that we got from a Instagram user about it. But what is the biggest negative that you see with patients or with the drug on the market today?
So I'll say that the majority of the positives outweigh the negatives. The biggest negative in my mind is muscle loss, especially as you get older. If you are in that age group over 50, where if you break a hip, everything goes downhill from there, that's where it gets kind of hairy. Proper education on diet, especially when you're on these medications, because they decrease your appetite. Everything sticks in your stomach longer. If you eat greasy fried food, you have acid reflux for 4 days because it's just sitting in your stomach. Proper dieting is essential in my opinion, but the biggest risk is you lose your muscle mass. So you trip and fall and you break your hip, break your leg, break your knee. And that can be the beginning of the end if you are 65 or older.
Yeah, and we talked about that with Rodney, our trainer. For him, he sees these as an adjunct to what he does because patients come in, they're on Ozempic, and he's still making them work out and do a bunch of stuff, so they're maintaining to some degree their muscle mass.
Stephanie,
and cost is the other thing we talked
about.
Cost is very prohibitive right now.
Stephanie on social media asked, what are the side effects? Aren't a lot of people having awful side effects because they aren't diabetic?
Yeah, I mean, not really. I mean, it's just GI upset, just like Zain said.
That's the only
the injectables. I think we talked a little bit about this too. The injectables have a little bit higher bleeding risk. Say people with nosebleeds and stuff, nosebleeds and GI bleeds, minor, usually not something that's going to kill you. And then the diabetic retinopathy. Have you read about that?
I have not heard about that one.
So there's some percentage of patients who are diabetic who do the injectables like Ozempic for diabetes and weight loss, and then end up with worsening diabetic retinopathy. Nobody knows why.
Interesting.
What about, those are some of the side effects. Obviously, cost is a big, downer right now because it's, it's not a generic drug. I mean,
It's not covered by Medicare yet either.
so, that's a huge downer. What would you say to somebody, again, not medical advice, but what would you just say to somebody who's kind of like on the fence about, do I take it? What are the side effects? Is it going to benefit my life?
So I'll phrase it this way. I think there's a field of medicine that's going to be completely gone in 3 to 5 years, and that is gastric bypass surgery for 99% of people.
Really?
Because the side effects of gastric bypass surgery are so horrible. If you get side effects, I mean, it's pretty limited, 1, 2, 3%, but if you get it, it's a terrible life. You're an ostomy bag, you're constantly in and out of surgeries, you've adhesions, all these terrible things. I've said this before and I've got a lot of flack for it, but that if you're in the position of choosing between trying out a shot or getting a gastric sleeve or a gastric bypass, I would absolutely opt for the shot. If you are on the fringe of being obese, I think, these drugs are fantastic for that. If you are obese, they're fantastic. It's the people that are, that are like me and Brian or whoever, that are athletic, that work out a lot, that do a lot of those kind of things, that just want to become like 2% body weight, then you're kind of, your benefit risk ratio is different. And so I don't think those types, I mean, I don't know if, the stars in Hollywood really need it, but, some of them have had amazing weight loss.
Right.
It just, I see it on social media. I mean, you can see it. You can see even your favorite medical creators. Some of them have lost a lot of weight in 6 months. I'm not naming names, but if you just go there, you can just scroll back. I mean, people have lost a lot. I mean, they look fantastic, and they don't admit to any of these things. But there's some out there that you're like, wow, you look great.
Yeah.
So if you're in that industry, it's fantastic. I mean, it's just a benefit risk benefit ratio. Yeah. I think the biggest thing that hasn't happened yet is the major corporations having, like the conglomerates like Nestle or Frito-Lay, Pepsi or whatever. Right. Those companies haven't realized General Mills. There's a giant industry that hasn't even been uncovered yet, that, hey, we can create better food that has all the micronutrients that you need, that isn't highly processed, that has the protein value, that can benefit those individuals that are on the fringe. And that is going to be huge once they realize it. The same thing goes with the insurance companies. Right now, they're like, it's $500 a month, $700 a month, $1,200 a month, whatever it is. It's too expensive. But if they realize that, hey, it can help with heart disease, back pain, shoulder pain, neck pain. It can decrease the amount of ER
millions
visits.
of dollars a month.
You're talking about billions of dollars of ER visits that are I mean, obesity is probably the underlying cause of majority of the symptoms, the majority of the pathology that we have in the hospital. I mean, it's just eating too much, and it's an American way of life. But these drugs are going to change. I think they'll change. They'll change the entire mindset. They'll shift people to start thinking healthier, eating salads, whatever it is. I mean, a lot of the questions, like the question you just got, the reason you have the acid reflux, the heartburn, is because that one meal a day you're eating like
it's
fried,
garbage.
Fried chicken, or you're having something that is very hard to digest solely in your stomach. And when you take these shots, the food sticks in your stomach for like 2 days.
Yeah. So you're saying like easier to digest foods could help that.
If you eat a salad, you eat some grilled chicken like that, you don't get the same GI upset that you get if you eat, a pizza.
Yeah, 100%. If you have a hamburger versus a salad. I mean, and just you can have an entire supplement industry born out of this, where it's, hey, we have protein dense, high electrolytes, high things that you need, minus the hard digestible foods that are, killing us.
Speaking of supplements, we should flip to the supplements.
Well, I was just going to transition to that. Great minds think alike.
Yes.
Dr. Zain Hasan, trauma anesthesiologist from Cedar Sinai Hospital in LA, joins us here. We're so lucky to have you in studio. Thanks so much. And we're going to switch exactly to it's a great segue to talk about supplements. Talk about your relationship with supplements and why you're so big on them, I guess.
So I think 80 to 90% of supplements are useless. There are about 4 or 5.
You just did a video on that with the milk thistle, right?
Milk thistle, melatonin.
Cleans your liver. What?
Yeah. So
we're gonna link all of them, by the way.
Yes, there are certain creators on social media that will push liver detox, which is crazy to me because your liver is there to detox your body, and they're selling these supplements like milk thistle to help your liver do what it actually does. The majority of supplements, I think, if you have a good diet, you don't need. I mean, I don't know if you saw the fluoride video that I put out, but there was a recent. I got a lot of flack from that.
I'm sure. From the dental community.
BS study, this and that. I just reported. I didn't come up with a study. Wasn't part of the funding for the study. I don't care. But I think if you live a healthy life and you eat the right amount of things, you don't need a lot of supplements. There are certain supplements that I personally take, magnesium being one of them. That's a really hot button issue. I think it's fantastic. Magnesium is a natural way to go to sleep. We use it in the operating rooms to decrease blood pressure, especially when you're pregnant. Everything that it does,
GI too.
100%. Yeah. Helps you poop, helps you move stuff to your stomach. But the biggest thing is it lowers your blood pressure. It decreases your anxiety, helps you sleep better at night. If you sleep better at night, you have a very productive day. I mean, you can wake up at 4:30 in the morning and work out with your trainer.
No, 2:30 in the morning.
2:30, oh my God.
Do his journaling.
That's a question for the end. I got to ask you about the gratitude journal. That's pretty cool.
Yeah.
But there's certain supplements that are pushed by the industry. Melatonin being one of them. A lot of people don't know that melatonin is a hormone. It's not actually a supplement. It's a hormone that's made naturally in your body. If you take it exogenously, meaning you take the pill over and over again, it'll decrease your natural release of melatonin. And then you see kids getting these gummies, which a recent study, maybe like 6 months ago, they tested 10 or 20 different gummies and they found varying degrees of melatonin. I mean, it could be subclinical levels, and then you had almost 10x the recommended dose. So it's crazy. They're just unregulated. It's like a free-for-all, wild west. And I mean, melatonin works. You take it once in a while, it'll help you go to sleep after a long flight or during a flight or something like that. But people don't think about it logically. If you take a hormone over and over again, it doesn't matter if it's melatonin or testosterone, your body's going to decrease the natural production of the hormone.
So you're saying magnesium could be the answer to some of that?
Yeah, we talked about this, magnesium and zinc. So, I mean, you mix those two things, you'll sleep great.
Yeah, and zinc is helpful with testosterone. Zinc is helpful when you're sick. So there's certain supplements that are fantastic to take in certain situations. I wouldn't recommend taking magnesium every single night because you're going to be tired the next day if you build up a high level of magnesium. But if you take it 3 or 4 nights a week, or like me, I take it twice, if after it's a call shift or whatever it is that I need to get a good night's sleep, I'll take a magnesium because, unlike alcohol or those kind of things, you don't feel groggy the next day and it's natural. But if you take anything, too much of it, your body will build up, you'll build resistance, you'll build tolerance, then you have side effects.
Did you see the article, speaking of supplements? So I've taken fish oil for 20 years probably. Did you see the article that you have an increased risk of AFib and sudden cardiac death if you take fish oil, exogenous fish oil? Did you see? There's a big study that just came. I wish I had it on me, but we should link that if we can find it.
Yes. Are you taking it still, or?
Well, I mean, till I run out.
We bought it.
I've been taking it for 20 years. I mean, what's another 6 months?
Yeah.
No, it was huge retrospective. It was like 40,000 people people who regularly took fish oil had higher rates of conversion to AFib and sudden cardiac death.
Wow.
Yeah.
I can't figure that out in my head. I would think that if you took fish oil for a long time, it would increase your chance of blood clots or those kind of things eventually if your body got resistant to the amount of fish oil.
They didn't really talk about it. I don't know.
The pathophysiology of it. But that's interesting. I got to read it.
Was there anything else on supplements that you wanted to touch on that we didn't talk about?
So the ones that I think are, nonsense, like liver cleansing, blood cleansing, milk thistle. These things are, they're just marketing schemes.
I literally have never heard of milk thistle until I saw your video. So I'm like, what in God's name is that even?
Yes.
It was a big push for a long time.
Really?
And I still get messages. You would be surprised. I got messages from all my friends that are naturopaths or whatever saying, "Oh, milk thistle is fantastic." Because I don't even know where milk thistle comes from. I'm just guessing it comes from milk, but they're like, no, it's so good for your liver. And then dandelion root. Just like crazy things like eating a dandelion is going to somehow detox your kidney. It doesn't make any sense logically to me. But there are a bunch of supplements that are just marketing schemes. Marketing employees to make you pay $20 for a bottle.
Yeah.
There are some that I think are great, like magnesium, vitamin D, zinc. Those are fantastic. Vitamin C if you don't eat,
if you're sick
or something, and iron if you're a vegetarian or whatever. But
what about a daily? Because there's a big controversy out there. Do you take a daily vitamin or not?
I don't. Okay. I personally, but I try to eat like a total diet. My majority of my diet is ground beef or ground chicken, rice, and then fruits and vegetables. So those are like I try to cut out a lot of the processed stuff. Try to get all my stuff naturally as much as I can. Probably 8 out of 10 meals a week. I try to eat some whole type of stuff. So I personally don't take a vitamin. My wife does. She eats a lot worse than me because she is a surgeon. So she does take a multivitamin, and she eats a lot more junk food than I do. But I have the time and I have the ability. I'm blessed. It's a monetary thing too. You have to have a certain amount of money to be able to afford these things, and that's a travesty in our country that people can't afford to
What
have.
they need,
Yes,
yeah.
they can't
To
afford
get broccoli.
broccoli, or just
Right.
ground chicken. Those
Right.
kind of things are expensive. It's cheaper to get a Pepsi and a bag of Doritos as opposed to a pound of ground meat and rice. So that has to change too. The public knowledge about it and the thought process behind it has to change. But yeah, I try myself to limit the amount of supplements, and I try to understand why I'm taking them. That's the biggest thing.
Yeah.
I have to have a purpose. I can't just take it because I saw an ad for it. If it doesn't make sense to me, I won't take it.
Is it good to take daily vitamin, or is it controversial?
It's super controversial. Yeah. So I mean, there's a decent amount of literature that if you eat somewhat well, not even as clean as that, but just eat not junk all the time, that you probably get enough of the vitamins, minerals you need. There's some essential ones that you may need, like vitamin E, vitamin D, that sort of stuff you may need to take. But so that there's a lot of controversy in the literature. You probably pee out most of the vitamins that you take.
Yep.
I do take it daily just because I mean, I can afford it, and if I pee it out, I pee it out. But if I get some benefit out of it, fine. And I don't think there's detriment to it. But I don't think there's a lot of good data of taking that.
Are you talking about over the counter, like Centrum or whatever?
Yeah. Mm-hmm. I do psyllium every day, though. That's one that I do. Yeah,
I don't know much about it. Tell me about it.
It's just like an insoluble fiber. Basically.
Okay.
So I just take psyllium husk, and keeps you regular.
Yeah. I do oatmeal. I mean, there's a lot of controversy over oatmeal. But, I've done some research into it. The glyphosate was a big thing. Getting glyphosate-free oatmeal, I don't get the IBS symptoms. I don't get the gas, the bloating. That's but it's expensive. It's not the cheaper oatmeal is the one that's high processed with the pesticides on it. So it's one of those things. You just have to find your own. It's very individual. I think it's very individual for each person. You have to find what you're capable of doing. You have to find something that you can do consistently.
Right.
Because I don't eat clean every single. I mean, the flight here, I had Doritos and all the stuff that I'm talking about. I had all that.
Biscoff cookie.
Biscoff, I skipped the Biscoff cookie, but I ate at the Delta Lounge. So I don't do it. I'm not 100% like some sort of like perfect person, but 80, 85%. If you can consistently stick with it, you'll lose the weight, you'll feel healthier, your back pain will go away, all those kind of things.
So I have to ask you, because there's a couple other topics that we want to touch on quickly.
I want to talk. You said your wife's a surgeon, so we got to talk about surgical subspecialties.
Let's do it.
Who to work
Yeah,
with.
let's do it. I want to ask you, because this has something to do with supplements and whatnot, but we had a question for Brian not too long ago about, hey, as an anesthesiologist, how do you make time to work out and to eat healthy, right? I mean, I can imagine your schedule in the trauma world is crazier than Brian's and more inconsistent with times.
Yeah.
So how do you balance working out, eating healthy, doing the research on some of the foods that you need to eat or want to eat?
Yep.
And how do you balance all of that? Because obviously you guys are healthy, you work out. How do you balance those things in your life?
So I'll start from the third question, move backwards. How did I learn about it? Social media. I mean, this revolution that even the stuff we're doing today, when I was a resident, I had no idea. I was eating terrible food. I had the crazy hours. I was overweight, tired, back pain, all those kind of things. In the last 2 to 3 years since I started doing so and paying attention to actual creators who are genuinely trying to tell you good things, not just selling you something,
right,
or just showing off their money or their cars or whatever. Those type of creators really enlightened me, and I didn't take everything as gospel. I made a video recently about one guy named Carnivore MD. He's this family physician out in California who just eats only meat, but he has good data points on certain aspects that I looked into and that I've adapted into my diet. So. That was the reason. That's where I got the knowledge, and I made my own game plan. I took my work schedule into account. I'm not up at 2:30, but I'm up at 5:30 in the morning. I don't have time to have breakfast. I got a toddler at home who's usually in our bed when we wake up, and he wakes up, and so I don't have time for breakfast. So I cut that out completely. I said, what kind of diet would work for me? The 1 meal a day diet worked for me. So I have my caffeine in the morning. For lunch, I also have caffeine. I hydrate during the day. Go to the gym, take a pre-workout, which I wouldn't recommend, for most people out there. But that's what I do because I'm still young enough to do that. Yeah. Take my pre-workout, workout, and then I have my meal. And then at the end of the day, I have fruits, vegetables, whatever it is for the second meal. And within like a 4-hour window. That worked for me. That type of schedule was easily adaptable to the crazy life that we live. But for you, for whoever's watching this video, it might be completely different.
Yeah.
You might be a night owl. You might have a different setup. But finding a diet that you can consistently stick to, that's the biggest thing. Because I think there's a stat, I don't know what percentage, but most people that go on diets fail, including Ozempic. There is a high amount of people that take Ozempic, lose a lot of weight, they stop the Ozempic, they rebound, and they actually gain back more weight than they lost. So it's whatever you can do consistently. It doesn't, there's no magic.
Yeah.
There's no magic to it. You have to just find something you can, and it took me years to figure that out. I was overweight till about, I had our son. I was probably 240 pounds after we had our son. I mean, we were just eating terribly, not sleeping, not working out. And then since then, now I'm down to about 165 pounds, like 8% body fat, which I'd never been in my life before. But to the credit of social media, to the credit of creators out there who said, hey, these are things you should try. These are things you should avoid. And to the credit of understanding how Ozempic works and those kind of things, I've lost a lot of weight that, I wouldn't have been possible before.
Yeah.
That's awesome.
Nice. And I wouldn't, let me make sure I comment. I wouldn't recommend drinking the amount of caffeine that I drink in a day. I go way over the 400 milligram.
Okay, all right. So how much are you drinking a day?
I would say I have an energy drink every morning, which I don't recommend for anybody. And then I would have 2 cups of coffee, which are about 80 milligrams each, right? So I'm looking at about 360-ish there. And then my pre-workout, which is another 150.
Yeah.
So I'm looking at about 500, 550, which is not crazy, but for the average person, I would not recommend.
Especially if you have heart condition, don't do that.
So yeah, don't copy me. I mean, use the knowledge that I give, that Brian gives, anybody gives, use that knowledge, but don't copy it word for word. Figure out what works for you. And that's why education is so important.
And it took you years to do it. It took you years too. So, well, I know you wanted to ask about the subspecialty of.
Yeah, I mean, I think it's worthwhile to talk about. I mean, somebody recommended that we talk about the the best and worst surgical subspecialist to work with. So, I mean, I'll go first.
Yeah.
I guess.
I remember we talked about this once upon a time.
Not publicly.
Oh.
Not publicly. So I would say if you poll all anesthesia providers, most would say that orthopedists are the most difficult to work with.
Difficult?
Yeah, the most difficult to work with. Now, I'm in a unique situation because I work almost exclusively with orthopedists. So I have a really good relationship with orthopedists. For me, and no offense to your wife, the toughest surgeons to work with are cardiovascular surgeons. I mean, I've had 25 or 30 I've worked with in my career, and most of them were just a pain. Bed up, bed down, bed left, bed right.
Yep.
Why is the heart not pumping enough? Blah, blah, blah. It's just
Meticulous. Are they meticulous? Are they
controlling? I'll tell you.
tread careful, tread careful.
to an extreme, right? To an extreme. And I think orthopedists tend to be the same way, actually. But I've got, again, I've worked with the same guys for 12 years, 13, whatever. So these guys trust me, and they don't bother me anymore. But the cardiovascular guys, I could never crack that nut. So.
What about you?
I would tend to agree with the orthopedist. I think neurosurgeons are very. I mean, if you are doing brain surgery on a little blood, it's to the point where it's just obnoxious sometimes. It's like, don't let the blood pressure get between. You have to keep it between 10 points, which is impossible for most.
No, it's totally possible. You take take the A line, the manometer, and you move it up and down and up and down.
Yeah, 100%.
So what we're talking about, if you put an arterial line and you get the blood pressure, it shows up on the screen.
Yeah.
When you change the height of that, it changes the blood pressure. So I've had multiple vascular surgeons, I won't say who made that same demand, and I just move it up and down to keep it.
So this is an interesting question for those who are not in the practice, right?
Yeah.
How much do you want to know or have to know about some of these subspecialties when you go into surgery with them?
I mean, I think a decent amount. I mean,
I would say the reason why we're paid the money that we're paid is to understand the dynamics of each, not only surgery, but surgeon, and balancing the two to keep the patient safe. I think that going back to our earlier point, AA, CRNA, MD, the biggest advantage that we have is we went to medical school and residency training with a lot of these folks. We saw the type they go through. I mean, becoming a surgeon is insane. In this country, all those work hour rules don't apply to majority of surgeons out there. They're working crazy hours. They're under a lot of pressure. Unfortunately, to this day, we have this culture of, breaking down your residents before building them up.
Like the military.
Yeah, just like demoralizing. So I see it. I mean, my wife was a resident. I've seen her go through the struggles. But to the point that you were asking, as an anesthesiologist, you have to understand not only the surgeon's wants, but the surgery they're doing and the patient that you have. So you have to kind of balance all three and keep it inside the Venn diagram. So I think that is a major part of anesthesia.
Yeah, I would agree with that. I mean, you have to kind of predict what's going to happen next. You have to know why are they doing, X, Y, and Z. If they do something different, like you probably do this too. You work with somebody enough, you get in a habit of like, okay, with CN, for instance. This is the implant's going to go in. He's going to put the Exparel in. He's going to walk out of the room. The PA is going to do some suturing. He's going to do this, right? So it's step by step by step.
So the habits.
You know if anything's out of order. You can even hear it, like the noises change a different way than normal, and you get to the point where you're like, yep, something's different. And you look over, like, what's going on? I broke the femur rod or whatever. So
what about reverse though? What about the reverse of that and what that person knows about?
Oh, they know nothing about anesthesia.
I would say they know very little.
Really?
The majority of surgeons don't know anything.
Do you like it that way?
I don't. I wish they would take an. I mean, this is back to the original point. A lot of the anesthesia is considered a service special. I mean, it's considered like a service, right? So you're just providing a service.
Yeah.
So a lot of people don't care to know because that's not pivotal to the medical hierarchy of the hospital. So they just want you to provide 100% perfect care, and then as soon as they're done with the surgery, that it just turns off and the patient wakes up. So that is a big part of anesthesia struggles day to day. It's like, if something changes and they take 20 minutes longer than they're supposed to, your anesthetic might wear off. And then you're like, oh, crap. And then they're like, why is the patient moving? Or they might take an extra 4 hours and then you don't have the medications that you need to keep them asleep. So, and the pain medications, you give too much. They're too drowsy in the PACU. They can't do their exam. So there's a lot of interpersonal dynamics, especially as an anesthesiologist, you go through that that's the reason we get paid what we get paid, because there's a lot of pressure that people don't see, but it can ruin relations. I mean, if you take too long to wake somebody up, or if somebody's not awake enough to get out of the surgery center by 6 p.m. and they have to pay overtime for the nurses to stay and somebody stay. So
they'll boot you. I don't want that guy back.
I don't want that guy back. I don't want that guy in my room. And it's nothing that you did. It's just that you didn't predict what they were going to do. And so that is the hardest. I think the hardest part about anesthesia is predicting what the surgeon is going to do, because you have such an array of personalities and such an array of skill levels. I mean, you probably know this really well. There's certain surgeons that can bang out a knee replacement in like 45 minutes, and there's other surgeons that'll take 4 hours, and you're like, what is going on here? And then you're like, should I give more pain medicine? Should I give less pain? So there's a lot of dynamics, and that anxiety, causes a lot of anesthesiologists to burn out publicly.
But they don't understand anything about anesthesia.
Like, they don't know anything. They think it's a switch, you just turn it off.
Turn it off, turn it on,
the airplane switch.
Well, guys, this has been a lot of fun, and I think we need to do it again.
Oh, yeah.
It's a lot of fun. And, of course, there's going to be a lot more content coming out between the two of them over the next couple of months and weeks and months and all that. And let's do it. Let's go out to L.A. and get a little taste of Hollywood.
Sounds good. Let's
get there before we're gone.
Oh, that's right.
Okay, so are you going to break some news on the podcast here?
Let's break it. As long as this comes out a little bit later, we are planning to head back to Pittsburgh. We had a fantastic time in L.A. I mean, L.A. I think is probably the best city to live in if you have a lot of money and a lot of patience. It's the best weather, best food in the country. But raising a family, starting from scratch is very tough. And we don't have family out there. So we are going to be making the move back to Pittsburgh the next 6 months.
That's an easier trip for us.
Yeah, that is. It's 5 hours.
It's easy to get to Pittsburgh,
Yeah, 5 hours by car.
Yeah.
You can get a lot of South Bend then.
Oh, yeah.
then I'll be a regular on this.
I love it. I hope so.
Yep.
Well, man, thanks so much for making time.
Yeah.
It's been an absolute pleasure, and I know Brian appreciates it.
Absolutely,
and,
well, I got to tell the story of actually how you and I connected.
Yeah.
So, and then we can obviously close out. But so I had, for some reason, even before we even got together and started doing social media, I had a TikTok account, and you had popped up, I think, just because I said I was an anesthesiologist.
Yeah.
So I had seen you before, and then I think, I don't know, you and I maybe followed each other.
Yeah.
And then you reached out to me when I went to Disney.
Yep.
And made the lightsabers.
Yes.
And then from there we kind of connected, and that's
Yes.
how we got a little bit
Yep.
The closer
awesome.
this all
And
happens.
because of that, we're going to Disney in August.
Nice.
Yeah, and we're gonna do the lightsaber.
You should,
Nice.
That's awesome.
Because I just like this. It looks like the coolest thing ever. I was like, is it worth the $400? And you were like, absolutely,
Absolutely. It was 100%. Yeah.
And where can people find you, by the way, on social media?
Oh, that's a good point. So if you just search my name on Google, I'll pop up with all of them. But usually it's either Dr. Zain Hasan, and then I think on TikTok it's still Doc Tarz, DOCTARZ. But everything else is Dr. Zain Hasan with the blue check mark. Because like you probably have a lot of fake accounts that now message people asking for money. So please, I never ask for. I never want any of your money. Don't want your bank accounts. None of that stuff.
I guess I never had to preface that, but
Yeah.
yes, I will never ask for your money either.
No, yeah. Well, thanks so much.
Anytime.
Really appreciate it. This has been Going Under Anesthesia Answered with Dr. Brian Schmutzler. We'll catch you in the next one.